board-certified cardiologist for over 25 years and at Borges Cardiology Group since 2007. His background includes time in EMS as well as an ER physician throughout the community. Undoubtedly some extraordinary days as a flight physician as well and a board member for the Borges in-flight during its operation in the mid-80s. Here to present with him as well is a nurse educator for Borges. She has experience in cath lab, cardiology short stay, the echo center, the chest pain center, and is a coordinator in regional STEMI for Borges for the last 6 years. I know many of us are just extremely happy that we have such an outstanding physician in our community and for our service. Here to talk to us about coronary anatomy and pathology, the good, the bad, and the ugly, please welcome Brooke Mishler and Dr. Robert LaPenna.
Thank you.
Can you hear me? Excellent. I used to work ambulance in 1964 in Grand Rapids, and at that time we worked in, it was a station wagon, basically a Buick station wagon. It would just fold down half of the back seat, and we had a stretcher on the other side. Cost us $5 for our ambulance attendant's license, and it was good forever. And we had to have a standard and advanced first aid card. It's pretty basic. And a lot of the guys that ran ambulance at that time would have either a service station, they'd be working on cars, and then they'd hop in the ambulance and take a call, or of course they were at funeral homes. And the larger hearses would act as an ambulance. So that was quite some time ago. And back in the 1950s and the 60s, emergency transport was predominantly for trauma. It had very little to do with the heart. If you had a heart attack in the 1950s, basically you were treated with narcotics for pain and sometimes antiarrhythmics. We had Lanoxin and quinidine, but the mortality rate was about 50%, and patients often just stayed at home. They seldom came to the hospital. If they did come to the hospital, they would be placed in a regular ward without EKG monitoring and treated once again with pain relief and some diuretics, which were quite ineffective, and sometimes with antiarrhythmics. Then the first big step in the treatment of coronary artery disease took place in the 60s when a physician named Killip in Rochester, New York, decided to put everybody with a heart attack in one unit and then put them on a monitor and treat their arrhythmias. At that time, they developed 12-lead EKGs, which were developed in Ann Arbor, Michigan. But it took a while. The EKGs had to be recorded on photographic paper, and they had to be developed in a darkroom. So it wasn't running an EKG and handing it right out. Well, Killip's activity in the 60s spread worldwide immediately because the first treatment of heart attack that made a significant difference and decreased the mortality from 50% down to 15 or 20%. The next big development in the treatment of coronary artery disease took place in the early 80s when people started opening coronary arteries either with thrombolytics or with angioplasty and stent placement, also with emergency bypass surgery. Now that this opening arteries saves heart muscle. So if we can control the arrhythmias, which is becoming more effective, and save heart muscle, then we're doing the job for the patient. Now, saving the heart muscle requires a time frame, because if you obstruct a coronary artery, there's a certain amount of time to open it up. So now all of a sudden, or even more so than before, getting a patient to the hospital with an acute MI is, in a timely fashion, is much more important. So trauma at one time was the big focus of attention for urgent transportation, and now acute MI has become urgent transportation to benefit the patient. Now what we're going to do today, and with the help of Brooke, is look at some angiograms. Once the patient gets to the hospital, I would like you to see some of the things that we do to help the patient.
talking about the quick transport, just to go over the AHA guidelines real quickly for everybody. The goal used to be for the regional hospitals to transport to a primary PCI facility. The goal was 120 minutes. And for patients presenting to a primary PCI, the goal for door to balloon was 90 minutes. And now it's 90 minutes for everybody. So we get patients from Hillsdale, Dowagiac, South Haven, it's 90 minutes. So what they do is they go by the door time. If the first EKG is positive for an acute MI, let's say the patient comes in and their first EKG is negative, then we go by the time that the patient's EKG became positive. We don't go back to the door time. It could have been 2 hours before. So our registries, ACC and BMC squared, they set up guidelines for these door to balloon times. We always say door, but it's not always the door time. Field activation is where we can make the biggest difference. So to get the process started, to get air care on the way to the patient. So we have an auto accept policy here at Borges. So everybody get your pens out because you're going to want to know Borges' pass number if you don't already know it. It's 226-4852. That's the only number you need to call from the field. I have a hot one here. We need to get them to Borges. So if you're out in a regional facility, air care will start heading that way while you're on your way to that regional facility to meet the patient. And that's how we can get to that goal of 90 minutes when some places are 60 miles away from Borges. If air care is not flying, continue on to the primary PCI facility, come to Borges, unless the patient isn't stable enough, and then you stop at the regional facility, stabilize the patient, and then bring them up if it's snowing or air care is not flying. Your documentation is greatly appreciated on-set time for our data extraction, and we really want to thank Air Care. You guys, I'm giving you a gold star for your documentation because we really, really appreciate everything that you do for us on our end because we're all in this together. So let's get started with our case studies here.
The first case, if you'll excuse the back of my head, this is...
Which one would you like? You get to choose. You get to click on it. You have the mouse.
Okay. This is just a pair of scissors. We're trying to mark out where to place the sheath. Then this is the sheath that's placed in the right femoral artery. And they inject a little contrast media. And you can see there's a grommet right here, so we can place catheters in here and not have any blood exit. So this is the right iliac, femoral, superficial femoral, and deep femoral. So we can put any catheters we want through this. There's a sidearm on the sheath. Take some pictures of the arteries. This is going to be a fairly normal. This is gas in the colon, in the small intestine. I'm not sure why they're taking so many pictures of the... This is a nice shot of the sheath. That's probably a 6 French sheath. Then we take pictures of the coronaries, and this is a normal. This is the catheter going up the descending aorta, goes down the ascending aorta. The tip of the catheter is here, and this is the right coronary artery. You can see the diaphragm here. You can see a rib, another rib. These are the vertebrae. This is called the PDA, posterior descending artery. So this is in the AV groove of the right ventricle, and the PDA goes down the interventricular groove between the two ventricles. This is the same artery in an RAO projection. It's normal. This is in the AV groove. I'm assuming you know a fair amount of anatomy. This goes back to the SA node in the right atrium. These cover the RV. Here's the vertebrae, the diaphragm. And this is the left coronary system, a different catheter. This is the left main, the left anterior descending, and the circumflex. The vertebral bodies are right behind this. The diaphragm is there. So we take, of course, multiple views of the coronary arteries because the arteries are 3-dimensional, but our pictures are only 2-dimensional. So we have to look at all angles to make sure we don't miss any hidden narrowing. Then we take a third catheter, put it inside the heart, the left ventricle, and this is a nice left ventriculogram because it shows a normal contraction here, then a series of ventricular beats. So if you can imagine a series of PVCs in a row, this is why ventricular tachycardia often does not pump blood. You can see the heart never really has a chance to fill and then eject blood. There's 3 or 4 PVCs in a row, and the heart chamber stays small, never fills so it can't empty. The aortic valve is right here, and you can see the coronaries on the epicardium on the outside of the heart muscle. Here's the right coronary artery, LAD and its branches. Once again, here's the diaphragm, nice view of the ribs and the vertebral bodies. Now, if you take a mental picture of this left ventricular chamber, this is nicely contracting ventricle. You hear the terminology ejection fraction. That's the amount of blood ejected with each heartbeat. So if this heart holds, let's say, for example, 100 cc's in end diastole when it's filled right there, and it ejects 70 cc's, then that would be a 70% ejection fraction. No heart has a 100% ejection fraction. That would be quite abnormal. In fact, there's a disease associated with that. So the terminology is a little bit funny. People will think I have a 70% ejection fraction. That means I'm 30% below normal. No, that means you're perfectly normal, because 70% is 100% of normal. So the terminology can be a little bit confusing. Next case.
All right, so our next case is a 68-year-old male who presented with chest pain, has a history of emergency bypass surgery 20 years ago. He had a left main dissection at that time. And now he came in having chest pain again.
This is a great case because he was working as a body man or frame. He did front end alignments at a body shop on Sprinkle Road. He developed chest pain, and the ambulance brought him to the cath lab, or brought him to the emergency room where he was in extreme trouble. And he was brought to the cath lab where we did an angiogram, and he had complete obstruction of the left main. You guys have heard the term the widowmaker. Well, this is the widowmaker. But 20 years ago, I happened to be involved in this case. We rushed him off to surgery with CPR in progress, and it was quite dramatic, and he survived. And he's done quite well since that time. He's now back with some recurrent pain, and when we did the left ventriculogram, we can see that he's had a significant heart attack. If you remember that last angiogram, the heart muscle was quite vigorous, and all portions of the heart contracted vigorously. Well, now the tip of the heart out here is, if anything, going in the opposite direction, and there are little filling defects. These are little clots that are inside the heart chamber, if you see this defect here. So the heart chamber has what we call an aneurysm. So there's a left ventricular aneurysm with some intracavitary clots. Now, clots inside the left ventricular chamber aren't all that dangerous because they get organized and are extremely fibrotic, so they're stuck to the wall of the inside chamber of the ventricle. If you get clots in the atria of the heart, that can be a problem because those are loose and friable and can migrate downstream. So this patient has a large anteroapical aneurysm. You can also see that he has a pacemaker. This is a pacemaker wire that's in the tip of the right ventricle. This is a pacemaker wire that's in the in the right atrium. These are the wires that hold the sternum together. And these wires up here, the surgeon put around the spot where the distal anastomosis of the vein grafts are located. We can assume that he has some patent vein grafts because he is alive. If he had no patent vein grafts with that completely obstructed left main, then he would not be able to survive. This is a shot of his native right coronary artery, And you can see it's a little bit ragged and irregular, but it is patent. This is the right in another view, and this is one of the vein grafts that the surgeon put on. So it's a vein graft to the left anterior descending. You can also see over here during the initial phase of the shot, there's a coronary stent in the right coronary artery. So you can see this little honeycomb tube, that is a coronary stent. So here's the proximal anastomosis of the vein graft to the left anterior descending. Here's the distal anastomosis. So a surgeon sewed this in, took the vein from the leg, sewed the distal portion to the LAD, and that's just a beautiful distal anastomosis. There's almost no visible transition between the vein graft and the artery. So it's an amazing result. The other important thing that this shows is generous collaterals. There are collaterals filling the circumflex retrograde. So the surgeons put a bypass on, and then Mother Nature put a bypass on, retrograde collaterals to the circumflex coronary artery. This is the same bypass in a slightly different view. This is the stump of a bypass. So one of Fred's bypasses is completely obstructed at its origin. This is a third bypass, goes to the circumflex coronary artery. It's getting a little bit ragged, but after 20 years or so, this looks pretty good. We're very happy with that. Up here's the pacemaker can or battery. This is again is the vein graft to the circ. So Fred, because his ejection fraction is now in the 30% range with an LV aneurysm, he's going to require a defibrillator. There's good evidence that people with an ejection fraction of 30% or lower are at significant risk for sudden death. So he will have his regular dual chamber pacemaker removed. He'll have another lead put in by an electrophysiologist, and then he'll have a different can up there which detects the heart rhythm. And if he has a run of ventricular tachycardia or ventricular fibrillation, then that new pacemaker can will emit a discharge and shock him back into a sinus rhythm. And you've all heard of that, the ICD, or the defibrillator. Next case. Today's climate, if Fred came in this the condition that he was in, there are a lot of, let's say, third-party payers that would say he would not fit the criteria to go to the cath lab or to go on for open heart surgery. We have criteria now that the government is trying to impose on us, and we're resisting a little bit, that saying that we should not take heroic measures to try to help somebody like that. He had all the criteria to say he would not survive. But at that time, we were a bit more heroic, and we were just embarking on these new forms of treatment, so we would be much more aggressive. Now, because of cost containment and regulations, we have to start getting a little bit more sensitive about who we take for emergency angiography and bypass. I'd like to take Fred to some of the meetings when they make these rules and introduce him, because he's leading a full, wonderful life. Interesting, he's his wife at that time, and we're seeing this phenomenon as well. Fred was extremely ill. He got better. Over the last 20 years, his wife got sick and passed away. Now he's remarried. So there's a complete reversal of emotions there that have occurred over time.
All right, our next case is a 50-year-old male presented with chest pain, history of open heart in 2000. He has diabetes, hypertension, high cholesterol, history of TIAs, positive smoker, social drinker, and a positive family history of coronary artery disease.
So, once again, you can see that he's had some kind of heart surgery. There are the stainless steel wires holding the sternum together. This is the right coronary artery. Contrast media spills out into the cusp, and this is a nice view of the aortic valve opening and closing. Here's the right cusp, the non-coronary cusp, and there's a third cusp, the left. If the patient had aortic insufficiency, you'd see this contrast media shoot into the ventricle. Now, if we look at his artery, you can see there's a significant narrowing out here. So the cardiologist, this is a guiding catheter. This is a coronary wire that goes down here. You can see the tip of the wire there. And this is a coronary stent between these two markers. So there's a stent being inflated in the mid-right coronary artery. And this is a shot after the stent is placed. So there was a tight narrowing there. This is the coronary guide wire. So it's a pretty good example of, I would say, about a 90% narrowing, placement of a stent, then nice resolution of the narrowing. Now the cardiologist took a picture of the vein graft to the circumflex, and you can see that there's a tight narrowing right here and a moderate narrowing just beyond that. So besides fixing the native vessel, I'm assuming that here's a nice shot of that narrowing of the vein graft to the circ. This is the coronary stent being placed between the two markers. And this is an angiogram of the stent to the vein graft to the circ. And just before the contrast media enters the vein graft, you can see the honeycomb pattern of the coronary stent with an excellent angiographic result. This is another view of the same vessel. Then this is the native left system, the left main, with contrast media spilling into the aorta. This is the aortic valve. The patient has a whiff of AI. Then there's a narrowing in the native circumflex. Another shot of it. So we'd call that subtotal obstruction of the circ. Another phenomenon that you can see here is there's contrast media going back and forth in the left anterior descending. That means there's a vein graft or an internal mammary artery graft going to the left anterior descending, so there's competitive flow. The LAD is getting flow antegrade through the LAD plus through a vein graft, and they're competing to go down the LAD. This is the coronary stent being placed in the circumflex, the native circ, and we'll see if we get a better shot of, and this is after angioplasty and stent placement. So there's an excellent angiographic result, and this patient at the same setting had a stent placement to the native right, the vein graft to the circ, and the native circ. So it gives you an idea of some of the things that we can do. Previous to stent placement, this patient would have had to go for a repeat open heart surgery. His first surgery was successful for a while. Now he's developed progressive disease in the native vessels, the right and the circ, plus the vein graft, he's developed disease. So he'd have to have a redo surgical procedure, but he was able to avoid that, and we were able to place coronary stents in the vein graft and his native vessels, and subsequently prevent a repeat surgery, which carries a significant increased risk for a patient. Okay.
Right, we have a 71-year-old male, post-operative study for a valve replacement.
All right. You can see the surgical wires holding the sternum together, and you can see an object right here intermittently. That's an aortic valve prosthesis. So the patient has had aortic valve replacement, and those are the two tilting discs made out of titanium, and they open and close with each heartbeat, and if you get just in the right plane, then they appear to be more dense. These are two wires that the surgeons put in at surgery, and usually they pull those out a few days post-op. Sometimes they don't come out easily. Then there's also wires, permanent pacemaker wires that the surgeons put in, plus permanent wires that the cardiologists put in. So there's a lot going on here. But the main reason I wanted to show you this is because I guess beauty is in the eyes of the beholder, but the appearance of that valve, that is a St. Jude tilting disc valve. This is the right coronary artery. It looks good. This is his pacemaker. It's an older pacemaker. These are older, what we call unipolar wires. They've probably been in there for 20 years or so. This is an arch aortogram, and you can see the valve is right here, and the arch, it's obvious to me, it might not be to you, but the aortic arch is severely dilated. The arch should be about 1/3 that size, or it should be about the size of that aortic valve. This patient subsequently underwent replacement of his aortic root. So Dr. Cagney, the surgeon, put a new valve and put a sleeve. He took everything out from here from the base of the heart up to the innominate. So the patient had to have replacement of his ascending aorta. He had to transplant the coronary arteries. You see the size of the heart valve there, which is about 1/3 the diameter. So when the aortic root reaches about 5.5 centimeters in diameter, then the risk of dissection or separation of the layers of the aorta, the risk of dissection starts to go up dramatically. So the surgeons can take the patient electively and put a new aortic root in and prevent the dissection of the ascending aorta, which is almost universally fatal. The patient did just fine. Another shot of the coronary system and the valve. So the patient is doing just wonderful. Unfortunately, you can see how his vertebrae are fused together. That's called spondylolithiasis, so he has a lot of back problems. But from a heart standpoint, he's doing just fine. Next. Okay.
55-year-old female, no previous cardiac events. Positive family history, positive smoker, obesity, and asthma. Presented with chest pain with radiation to her jaw, positive troponin, no nausea, no vomiting, no shortness of breath or diaphoresis. EKG showed greater than 1 millimeter of ST elevation in lateral leads and reciprocal ST depressions in the inferior leads on the 12-lead EKG.
So,
sorry. Hold on 1 second, Dr. LaPenna. I'll make it bigger for you. There you go.
there you go. Thank you. So she came in with an acute MI, and by angiography, she had complete obstruction of a diagonal branch. It's a little hard to appreciate here, but it'll get easier. You can see the left anterior descending is here, and there's supposed to be a branch coming down here called a diagonal branch. The cardiologist took multiple views to try to sort it out. This is the left ventriculogram, which shows that the front wall of the heart from here on around to here isn't moving at all. So there's a good-sized heart attack in progress. The cardiologist did get a wire down the diagonal branch, and here's the balloon, and took a picture. Now we can see the diagonal branch starting to show up. And it was completely obstructed right at its origin off the left anterior descending. We call that a flush obstruction right at the LAD. And obviously it's an extremely important vessel because the left ventricle looked really bad. He's inflating again with a balloon in the diagonal branch. And after inflating in the balloon, apparently he wasn't happy with that because he kept on working on it. He has real good flow, fixes it again, and I believe put in a stent. Now he has 2 wires. One wire's going down the diag, and one wire's going down the left anterior descending. And now he has a balloon in the left anterior descending, and it looks like a stent in the LAD. What happens is if you have a flush obstruction, this is a nice shot of the LAD after it gets fixed, but now the diag is tight again. There's a phenomenon called snow plowing. It's if you have a branch that is flush occluded and you fix the vessel that's completely closed, it will cause plaque to shift into the other branch, and that's called snow plowing. So now you're trying to fix two branches, so it often takes two wires. So he's starting to get a result that he's happy with. The patient was on the table for a long time, and this is the bladder full of contrast media. Poor patient really has to go. But it was an excellent, so it was an acute MI involving the diagonal branch. They fixed the diag and experienced snow plowing of plaque into the left anterior descending, requiring a two-wire technique and fixing both branches. The final result was excellent, and hopefully the anterior wall, which wasn't moving, is what we call stunned. It's a lot like a concussion. Over time, the heart muscle and the anterior wall will start moving again. Give it a week, give it 3 weeks. We could repeat a left ventriculogram and find out that it's back to perfectly normal with vigorous overall contractility. That's really what we're shooting for. Now, sometimes if a patient like that has cardiogenic shock or arrhythmias, there are other measures that we can take. For example, placement of a balloon pump catheter or a temporary pacemaker. Leave that in for a few days until the anterior wall starts to contract. And over time, the blood pressure will start to creep up and the urine will start to flow, the lungs will clear, and everything will get better over a 3 or 4 day period of time with balloon pump support, maybe some inotropic drugs and that sort of thing. Next case.
All right. We have a 77-year-old male, no previous cardiac events, high cholesterol, hypertension, quit smoking in 1980, has a pacemaker, thyroid disease, and has had a stroke from a TBI. Presented with angina, with radiation to his back and the shoulder blades for 3 days. On average, patients wait 2 hours before they call 911 after having symptoms of an MI. This person waited 3 days with increased shortness of breath, weakness, nausea, and when they came in, they did have a positive troponin, but it was not very high at all. Let me make this big. There you go.
So they're getting ready to place the sheath. I have no idea what these are. There's a sheath placement. He's had some surgery down here in the groin area, but I don't know the history on that. This is a shot of the right coronary artery, which is completely closed, and there are collaterals from the proximal right to the distal right. You can see the pacemaker wires. So that's probably not the acute event. This looks like it's been old, severely diseased vessel. So they take pictures of the left coronary system and can see that there's a narrowing involving this, we call that an intermediate branch, as well as the native circ. All the vessels are rather small in caliber. So the cardiologist decided to go after these two circumflex branches. You can see there it's quite tight, and it looks like the left anterior descending is very small in caliber going down here. This is the distal right coronary artery filling by collaterals off the left system. So I'd rather have 1,000 collaterals by Mother Nature rather than one man-made bypass. We like to see collaterals filling the distal right. The collaterals only get better over time. They never close, they never go away. You can see the severe disease involving the proximal circumflex, and a cardiologist might look at this and think that the patient might be a candidate for bypass surgery. They could put a bypass on the two circ branches. You can see a ghost of the LAD out here. It is subtotally obstructed, as well as the right. So the patient could get a bypass to the LAD, two circ branches, and possibly the right. If the patient is not a good candidate for some reason, for example, bad lungs or other medical problems, then we go after it with angioplasty, which it was done in this case. Kind of trying to find the right, just the perfect angle to set up for the angioplasty. The cardiologist is trying to open the left anterior descending. Here's a wire kind of heading in that direction. Wire down partially the left anterior descending. Making a little bit of progress. We're restricted somewhat by the amount of contrast media. You know, the contrast media is toxic to the kidneys, so we might be limited to 300 or 400 cc's of contrast. Now he has the catheter down the left anterior descending, or the wire down the left anterior descending, and now it's starting to open up. These are more pictures of the left anterior descending, getting fixed, and this is a coronary stent going in the LAD. So he took a vessel that was kind of a little spider web, worked on it with a wire and a balloon, placed a stent, and now it's starting to plump up a little bit and show some improved flow. There's another, either a balloon or stent being placed, hard to tell. Another view of the same. Let's try to get down here. Okay, now the vessel's looking just fine. The LAD is widely patent with brisk flow, and the patient came back, I don't know if we have the angiogram, the following day to have the circumflex fixed. So it was recanalization and dilatation to the LAD with a staged procedure, meaning that they fixed the acute problem. He came back a day or two later, had those two branches of the circumflex fixed, and the right is covered by the collateral, so that didn't really need to be fixed. So there were two options: send the patient to urgent surgery for a vein graft to the LAD, circ and right, or fix the LAD with angioplasty and stent placement, then bring back as a staged procedure to fix the two circ branches.
Now, this patient also, even with the positive troponin in their symptoms, they did not have any ST elevation. This was a non-ST elevation MI. So
the collaterals are nice to have because they're so safe for the heart, but they can trick us because a patient can have an enzyme bump with no EKG changes or chest pain, or have chest pain with no enzyme bump or EKG changes, or any combination of above. So we like collaterals, but they can cause a very confusing clinical picture. Also, if there's a completely obstructed vessel like that, collaterals can, in a good way, maintain viable heart tissue in that region. So it gives us a lot of extra time to fix something.
all right. On to a 68-year-old male, history of COPD, smoking history, quit many years ago, congestive heart failure, asthma, AAA repair, and stents in the past. This patient came for a cardiac cath because they needed cardiac clearance for hernia repair. Experienced some chest pain, shortness of breath with exertion, went through a nuclear stress test, and it was abnormal.
This is a left ventriculogram in the RAO projection. And you can, if you remember back to the first case that we looked at that had the normal vigorous ventricle, this is an example of what we call cardiomyopathy. The heart muscle is enlarged and severely hypokinetic. The ejection fraction here is in about the 15 to 20% range. So this is a patient that has disease of the heart muscle itself, not necessarily the coronary arteries. This is a patient that would have to have a defibrillator and then go on certain medications to try to improve heart muscle function. So if you hear the term congestive cardiomyopathy or idiopathic congestive cardiomyopathy, that's what he has. He also has coronary artery disease, but the surgeons fixed him and did a good job. This is a vein graft to the right coronary artery with a beautiful distal anastomosis. This is the same vein graft in another view. And you've heard the term internal mammary artery. This is the left internal mammary artery, which originates off the left subclavian. It's taken down from the inside of the chest wall. And the side branches are clipped off, and then the vessel, the internal mammary artery, is sewn into the left anterior descending with a beautiful distal anastomosis. This shows some of the intercostal vessels. You see these little tributaries underneath each rib. So this isn't, when you hear somebody talk about a lima, this is a lima to the LAD. You can do a lima to the LAD or to any of the other coronary arteries. Nice thing about a lima is it's an artery, so you're sewing an artery to an artery. The other bypasses that we looked at, these are veins that were taken from the leg or the arm. So this is a vein sewn to an artery. And there's a tendency of veins, of course, have a much lower pressure throughout their life. So the pressure inside my venous system might be 8 to 12 millimeters of mercury forever. So a vein is designed and built to handle low pressure over a long period of time, whereas an artery is designed to have a very high pressure, 120 over 80, and a pressure that's quite phasic. Goes from 120 to 80, 100,000 times a day. So it's not really natural to put a vein on an artery. And these tend to deteriorate much quicker than an internal mammary artery. So if a person has an internal mammary artery graft, this will last forever. 30 years from now, that'll look exactly the same as it does today. They don't develop plaque in the internal mammary arteries like they do in veins. So the patient will be at high risk for surgery. Surgical risk is based more on LV function than on the coronary arteries, and he has severe LV dysfunction. So he'll need adjustment in his medications, and he'll need a defibrillator, but there's nothing to fix because his heart muscle problem is not related to the coronary arteries. Next case.
Last and final case this morning, 60-year-old female who presented with chest pain.
This is an interesting case because we originally heard that she had a death in the family. We didn't know exactly who. The rumor was it was her son or her brother, but she was extremely emotional. And when she got here, I was reading the emergency room record, and it said that I think her dog died. And then when I was talking to her, actually it was that she had an argument with her son, and her son abused the cat. So it was a series of, the important thing was that she had an acute psychological trauma, but the story kept changing. Here's her right coronary artery, it's perfectly normal. Here's the right and the RAO projection, perfectly normal. The left coronary system looks good. We take multiple views. The vessels are a little tortuous, and we see that in people that have hypertension. But the heart muscle is quite abnormal. You can see that there's extensive hypokinesis, decreased function. It almost looks like a mushroom where the base of the heart is contracting nicely, and the remainder of the heart is quite sluggish. That is called in Takotsubo cardiomyopathy, Takotsubo, Takotsubo. And it's named after some kind of fish in Japan, an octopus of some sort. It was described in Japan, and it's associated with an acute, severe psychological trauma. The mechanism is not known, but it's called Takotsubo cardiomyopathy, It does get better, but the patients present with an acute MI syndrome. They have chest pain, an enzyme bump, and some EKG changes. We take a picture of their coronaries, and the coronaries are perfectly normal, but the heart muscle is severely abnormal. So we treat them with ACE inhibitors and beta blockers, and virtually 100% of them get better, assuming that they don't have cardiogenic shock or arrhythmias during the acute phase. So this is a very unusual diagnosis, Takotsubo cardiomyopathy, that you might hear about, which is, to a cardiologist is kind of entertaining. We know the patient's going to get perfectly better, so it's a nice thing. So basically the heart is separated into 4 different components. The component that we discussed primarily today is the coronary arteries. That's what we can fix, and that's what requires urgent attention from providers that are in your position. The other 3 components, the valves of the heart, seldom do they cause an acute problem that require urgent attention, although occasionally they do. The third is the electrical system of the heart, which we're not really discussing today, but at times, if a person has profound bradycardia or arrhythmias, that can require your help. And then the fourth part is the heart muscle, which once again doesn't usually have an acute problem requiring urgent transport, but is a factor involved in the big picture as we discussed today. Are there any questions? So we got a quick rundown of coronary anatomy, acute MI, somewhat. Yes, ma'am. She asks, does the presence of comorbidities affect the development of collaterals, and how does it impact as the mortality and morbidity? The collaterals form over time, and they are formed by having a tight narrowing in one artery. This is one reason that a young person might have an acute MI and have a higher mortality rate, because they haven't had time to form generous collaterals. An older person, an 80 or 90-year-old, has an MI, and they might tolerate it better because their narrowing developed over many decades, and their heart had a lot of time to form generous collaterals. So if a 30-year-old has an acute MI, chances are they're not going to have a lot of collaterals. Now, having other disease processes like diabetes, hypertension, or that sort of thing, that does not affect the growth of collaterals. It's purely a time thing and a supply and demand thing. If the heart muscle is demanding blood and it can't get through the native pathway, then Mother Nature will naturally grow collaterals over time.
Anything else about door to balloon, STEMI patients? Anything?
Okay. We're going to have a 10-minute break then.
Thank you.
You bet.